So welcome to Genomic Education in Renal Health. And this event was requested by Renal Genomics, the NWGMSA and KQIP education event. So that was requested by them, and they are running an education day, which I've emailed you all, so hopefully you should have received that next week. I believe now it might be at capacity, but there might be some spaces available, so do try and get on if you can. Just a quick look at our agenda again, and I will shortly be handing over to Professor William Newman. So thanks very much, Bill.
Perfect. Okay. Hello, everyone. Thanks for joining. I'm Bill Newman. I'm a clinical geneticist here in Manchester. And I thought just for the first few minutes, what we'd try and do is just orientate you a little bit, if you're not familiar, it becomes increasingly complicated, as to all the moving parts of the genomic medicine service and how that all works, so that will then allow you to understand where things are up to. So, of course, there have been genetics departments around for a very long time, over 50 years in Manchester and in Liverpool. And those clinical genetics services are made of clinical geneticists, genetic counsellors, support staff, provide services traditionally to individuals and their families with rare inherited conditions. So in the past, often chromosomal disorders, developmental disorders, but over the last number of years, increasingly working with families where there's a strong family history of cancer or late onset disorders. And a number of those clinical genetic services have had laboratories linked to them that provide those genetic tests. So in the past, they were all basically delivered on a sense of, to some degree, clinical need, and to some degree the local interests and expertise of the clinicians in the region. And some of that was also linked into the commissioning. Now, lots of things have changed in the past decade to try and coordinate genetic services more effectively. So on the laboratory side of things, the big change that happened was about 3 years ago when all genetic testing became nationally commissioned. So any individual who requires a genetic test and meets the criteria for that test, their clinician can order that test, and they don't have to worry about who's going to pay for it. It's all paid for centrally. And there was a fusion of a number of laboratories, such that in Manchester and Liverpool, they've become a joint laboratory and provide genetic testing services across the northwest. But for some indications like cardiac disorders or metabolic disorders, immunology disorders, for a much broader population. We're not, as you're aware, the specialist laboratory for renal disorders. So that was the change to the laboratories that's happened. The genetic services are still undergoing some changes, in that the service specification is due to be out. Well, it was meant to be out this month, but we've only got one more day of this month. So hopefully that will be out very soon, and that will guide how genetics is being delivered. But fundamentally, we realise that genetics has to change, and I'll touch upon that in a second. But one of the ways that it's been changed is by thinking about what services we need to deliver, what new technologies are in place, and how we can make the best use of that. And that's what the Genomic Medicine Service Alliance was set up to do. So we don't see patients as such, even though I'm the clinical director of it. My role is really to look at the new things that are happening in genetics, be they new types of disorder that we need to develop pathways for, or there are new tests that we need to deliver in the laboratory, and how they can be embedded in clinical practice. So the GMSA, the Genomic Medicine Service Alliance for the Northwest, was set up a couple of years ago, April 21, and it links in across the region with the NHS NHS medical director, but links into lots of other programs of work going on, be they in the cancer alliances, across public health, across the ICSs, and also taking the patient voice to drive forward some of our thinking. And one of the things that we've been very keen to do is think about how we can engage better with our community. So we're very conscious that genetic services have been underutilised by patients and families from lower socioeconomic groupings, but also from certain ethnic groups. And so we've been going out into the community, particularly with the Pakistani and Bangladeshi community in East Lancashire, across Greater Manchester, talking to them about what genetics is and trying to link in and make sure that they're aware of what it is we do and why. And some of the reason for that within the Bangladeshi and Pakistani community is because, one, they're a large population, particularly in the northwest, but also because they have significant health problems, be they cardiovascular disease, diabetes. The higher rates of consanguinity mean that there's a much greater risk of autosomal recessive disorders. And when we do genetic testing within that population, often we have very little control information to compare that against. So you'll be aware that there's this amazing resource in the UK called the UK Biobank, and of the 500,000 people that provided samples to that, only less than 3,000 of those were from the South Asian population. So we have also been involved in a number of projects. These have been run at a national level, and they have encompassed what are probably more common clinical scenarios. So patients with Lynch syndrome, so that's early onset bowel cancer or endometrial cancer. We've known what we should do for those patients in terms of offering genetic testing to see if other family members are at risk, offering screening to other family members, but that's all been done in quite a piecemeal way. And so some areas it's been adopted and it's very clear who gets referred to who, but in other places that's been less so. So we've been trying to ensure that there's a consistency of practice across our work. Likewise, for the introduction of a new test called DPYD for patients before they get cancer treatment, we've been making sure that not only is that testing being used by all doctors and pharmacists, but actually they're then making decisions about chemotherapy based on those results. We've had a number of regional projects, and these have been focused just within the Northwest. So one has been around how do we provide genetic services for either individuals who have been looked after children or are looked after children in terms of their own health. May they require some genetic investigations if they don't have any knowledge of their biological family, but also when they're thinking about having children of their own and what the implications there may be. But you'll be aware of a project that I've been working with renal physicians across the region to really understand how we undertake mainstreaming of genetic medicine. And the point around that is that as we increase our use of genetics across clinical care, we need to ensure that this isn't all sitting with clinical geneticists and genetic counsellors. There aren't enough of us. It's not appropriate for people to have to wait for months to get to see us, when actually clinical services, be they in cardiology, oncology, renal medicine, can offer genetic testing, and with the right support and a right infrastructure, patients can get that clinical information which might drive clinical decision making much more quickly, and from a clinical team that they're already linked into, rather than needing extra services. I'm sure that'll be something that Helen will touch on in a minute. And so I just want to finish with a final example of a piece of work that we've been doing, which gives a sense of how we can use genetics in a common clinical scenario and not allow ourselves just to think this is something that's just around very rare conditions for a very small number of people. So you'll be aware, because you'll all use this medicine, gentamicin, that 1 in 500 individuals, when they're given gentamicin, are at risk of going profoundly and irreversibly deaf because they've got a change in their mitochondrial DNA called the 155A to G variant. Now, if you have a child with a urinary tract problem or cystic fibrosis, you can undertake a genetic test, get a result back in 3 to 5 days, and then in the future you will know if they ever need gentamicin, whether it's safe to give it or not. But the scenario is slightly different if you're in a situation where you have a very sick child, or a child that is being admitted to the special care baby unit, where you need to give the antibiotics within an hour of them arriving on the neonatal unit. And so waiting 3 or 5 days doesn't work. So with a local company in Manchester, we have created a genetic test which you can use at the bedside with a cheek swab, and in 25 minutes you can get a result. And in theory, that should allow us to screen the 100,000 babies every year that go on to NICU, and of those avoid 200 babies going deaf. So that's, in theory, sounds good. Can we actually do it? So we undertook a study to look at that, and we saw that the time it took to get the antibiotics into babies was exactly the same before we introduced the test to when we introduced the test. And we were able to find that 3 babies out of the 750 that we tested, so more than the 1 in 500, had this variant, and we were able to give them an alternative antibiotic. So that prevented them from going deaf. And that all sounds great and fancy. And of course, there's a cost associated with introducing new testing. But if you can avoid those 200 children every year requiring cochlear implantation, you're probably going to save the NHS somewhere between £5 and £7 million a year. And NICE have just given a provisional approval for this to be rolled out. So we're keen to look at other clinical scenarios where rapid knowledge of, be it gentamicin sensitivity or other situations where you might need a rapid result to inform clinical decision making, is something that we're keen to explore with you. So I'm going to stop there. I'm happy to answer any questions either now or at the end, and thank you.
That would be great. Thank you so much, Bill. That was really, really interesting. So if you have any questions for Bill, you're free to pop them in the chat, and we'll have some question time at the end. We can, keep them for a sort of a slightly later date. That was really interesting. So I'd now like to hand over to Helen Stuart, who I believe, are you all right to take control, Helen?
I thought I was failing to unmute myself. Yes, so hopefully I have taken control now.
You have, it's perfect. Thank you.
So hi, so I'm Dr. Helen Stuart. I'm a consultant clinical geneticist in Manchester. I'm also a clinical lecturer. So in addition to my clinical work, I also teach primarily on an MSc in genomic medicine, which may be of interest to some of you in that it has CPD-based units which can be funded by HEE to be taken to learn more about genomic medicine in general. Okay, I need to find the right bit to press. The other thing to note, I think these will be shared. These are my email addresses. When it comes to renal genetics, I'm very happy taking inquiries from people. So just to really mention renal genomics in Manchester, at the moment we run in a structure where there are 2 multidisciplinary clinics. So we have a clinic which consists of myself with clinical genetics support, but also a nephrologist, usually Dr. Hillman, previously Professor Adrian Wolf as well. And more recently, we've got a specific genetic counselling clinic. However, the big theme, as Bill has introduced, is mainstreaming the testing. So historically, these clinics have been going for a long time. We take referrals. Usually the referral were for individuals who'd had no genetic testing done prior to us seeing them. Increasingly, what we'd really love to see is to be seeing in these clinics the really complicated cases where there's questions about what genetic tests should be done, and increasingly using the counselling service to counsel families where a genetic diagnosis has been found and more complicated questions have come up. So when a patient with a renal tract abnormality and a renal problem is seen in clinic, obviously the primary question and probably the most important question is what their management is going to be, and that's not necessarily where genetics comes into it, but just certainly understanding the underlying basis of an individual's condition can affect their management significantly. So a lot of the disorders seen in nephrology clinics won't have an underlying genetic basis, but for those that do, or there's a suspicion that they could do, this slide is meant to present a way of thinking about this. So one way to think about monogenic disorders, which affect the urinary tract, the renal tract, is to think about what area or aspect of the renal tract's affected, so the glomerulus. And you can usually get an indication of this by how a patient presents. And this is an important step when you're thinking about the underlying genetic basis, because this is the basis of how you choose any testing you do. One question to ask is whether an individual you see has got a syndromic presentation, as this would impact what genetic investigations would be appropriate. For example, if you see a patient with proteinuria, do they have other syndromic features, such as having joint problems or nail dysplasia that could suggest nail patella syndrome? We also know that quite a few of the conditions which are primarily treated by nephrologists can be almost thought of as external conditions, so things like problems of the complement pathways, and also the metabolic conditions such as Fabry's disease. So the reason I've included that is this idea of finding a diagnosis for a patient is important. It affects their management. It's important information, and this process of thinking through, well, where to go next. Bill didn't include this, but I'm including this. This is really hopefully useful information for anyone who's thinking about testing. These are the sources of information about the tests available at the moment. So we've got a genomic test directory. This directory is changed every now and again. It's worth accessing on the web rather than just keeping a static copy of it. It is quite has a quite strict guidance for who is eligible for specific tests, but I think it's important, and also who can request them, but I think it's important to remember these things are flexible. So if you have a patient who you think might have a genetic condition, I think it's important that everything's done to access appropriate testing for them. I've mentioned the panel app here just because it's a useful source that if you've got a specific condition in mind, you can find out which particular test to request. I'm not going to go through how to request a genetic test. I'm very happy to answer questions about that in general, and also have put in references to our website for the Genomic Lab, which provides information. This is the test directory, all sort of selected aspects of the test directory as it stands. It's a reasonably helpful document, but it gives you an idea about what tests are available to people. I take the turnaround times with a giant pinch of salt, but you can see that a lot of these tests that are available are really helpful. You can see individuals and know which tests would be appropriate for them to access. And I'll talk a little bit briefly about the different techniques as well, just to give people an idea. From a practical point of view, I'd like to point out two of the whole genome sequencing options, which I think, and we don't primarily, which can, well, they can cause a bit of stress. So there's the whole genome sequencing option for individuals who have an explained early onset end-stage renal disease. This was initially eligible only to paediatric patients. It then increased, I think, to the age of 25 and has now increased to 36. I hope that actually this will be a test that is available much more broadly for individuals who have unexplained end-stage renal failure, independent really of their age. And certainly I have been requesting the test and usually having it accepted for individuals who are much older than 36. So I think it's potentially a very useful investigation, particularly when people are anxious about the risk to their children. The other thing to point out is often for an adult with end-stage renal failure, you wouldn't think of carrying out congenital malformations and dysmorphism syndrome gene panel just because of its name, but this includes a lot of genes which are relevant to the underlying etiology of adult renal disease. I've also wanted to point out that we do have a lot of our genetic tests, they take a long time. They're not what you're primarily thinking about when you're seeing an individual in clinic. Often you're thinking about things in the much more shorter term. So genetic testing might not feel like a priority. We do have a test for people who are very unwell, where achieving a genetic diagnosis quickly can be important. One of these is R14. It has a description for unwell children. We have used this in adults who are very unwell, where it's, for example, where we think maybe they could have a decompensating metabolic condition where achieving a diagnosis would be important. Okay. So this is just a note on genetic testing. A lot of our tests at the moment are all based on one particular technology. And produce a large amount of data, and I think it's important that individuals we see in clinic understand that there is a large amount of data, and there'll be a large amount of data that's being held and also being analysed. A lot of our panel tests are based on this, though, focused clinical exome tests based on whole genome sequencing. From a talking to patients point of view, the potential outcomes of these are very similar, and the amount of data is very different. But I think talking to people about this process can be helpful. So I also mentioned microarray. Microarray is being superseded, I think, by whole genome sequencing, but it looks at the sort of whole genome copy number. We know certainly for individuals who, for example, have got multiple structural abnormalities or learning difficulties, there's a reasonable chance they'll have multiple genes deleted or potentially duplicated in an explanation, and that would be the test to go for. So if you see an adult with renal problems who additionally has had developmental problems, this is a worthwhile first test. At the moment, we don't have testing for MUC1 in the UK. It's associated with a type of tubulointerstitial kidney disease, and because of the nature of the genetic variant, it can't be picked up particularly well by current technologies. My hope is that it will be available in the UK soon, but it's one to think about if you're sure someone has got tubulointerstitial kidney disease but have not been able to find a pathogenic variant. Okay, to speed on through, because I'm aware I'm talking quite a lot. I thought I'd briefly talk specifically about this whole genome sequencing panel. So for cystic renal disease, it contains a huge number of genes, 90 genes. The majority of them are actually associated with ciliopathies such as Bardet-Biedl syndrome, Joubert syndrome. However, the majority of patients who have testing via this panel will have either a clinical diagnosis of autosomal dominant polycystic kidney disease or a suspected diagnosis of autosomal dominant polycystic kidney disease. And this can be a really helpful investigation. I think that it is a barrier at the moment for people accessing this testing, that it is via whole genome sequencing. I hope that as nephrologists get more confident with requesting whole genome sequencing, this barrier will reduce and more people will be able to access this testing. In some places in the UK, there's a move towards testing everyone who's got a diagnosis of ADPKD. I don't think that's really happening in the Northwest yet, but certainly I'd like to think that people who would benefit from testing are able to access testing. And in the future, it will be important for stratification. At the moment, it's most important for situations such as live donor, predictive testing in the family, reproductive choices, and I'm going to talk a little bit about atypical cystic renal presentations just for a little bit of interest, hopefully. I don't think these images will project particularly well, but I wanted to include something other than words. So I've got 4 cases, hopefully to emphasise the benefits of testing people who've got atypical presentations. You'll note there's a tendency towards paediatric cases, and I think this is a reflection on things historically, that historically we tend to test far more children than we would adults. I think it's important to, I don't know, almost correct that now, because there's a lot of adults who should be having genetic testing, would be eligible for genetic testing, and are sadly missing out on it. So these stories are very paediatric based, sorry about that. So the first one is an antenatal diagnosis of echo-right kidneys, postnatally slightly enlarged, some cyst, mild renal impairment and hypertension. So that was all before the age of 6 years. The parents had ultrasound, dad had a couple of cysts at the age of 30, mum had a normal scan. The second case, again, was a child who had a UTI when they were a few weeks old. They'd also got post-axial polydactyly, but that was not thought to be anything very exciting. It was just a little nubbin of skin. They were found to have a single cyst on their scan after their UTI, and their parents, who were in their 30s, had normal ultrasounds. The next one is a child who had was a case that's actually surrounded with a huge amount of anxiety. So this baby had been recognised antenatally to have enlarged, bright kidneys. Postnatally, they continued to have bright kidneys. The parents were counselled that this child might go into renal failure very early on, and she didn't. She just kept going with her bright kidneys, and in late childhood was recognised to have a cyst. Somewhat belatedly, her mum had a scan for a different reason and was found to have classical ADPKD, and her dad was found to have a single cyst. The fourth case is an antenatal detection of unilateral, so one-sided enlarged cystic kidney, which because of its asymmetry is thought to be a cystic dysplasia. As this child grew up, he continued to have these asymmetrical kidneys, but started to develop cysts in increasing numbers of cysts in both kidneys. His father was found to have one multiloculated cyst, which caused a bit of panic, in that there was a thought for a while this could have been an incidental finding of malignancy, but was ultimately reassured about that. So these are the results, and hopefully this is a little bit of interest, but also sort of emphasises what, when you start testing atypical individuals who've got atypical presentations of cystic renal disease, what you may find and what you might want to counsel people about. So this first case turned out to have a biallelic PKD1 change. So biallelic changes in PKD1 can cause an almost like autosomal recessive polycystic kidney disease presentation. In this case, the child has a pathogenic variant and a likely hypermorphic variant, so a variant that means they've got a condition that's perhaps slightly worse than typical ADPKD, and is very interesting. It's interesting for counselling the family about what this might mean for the mother who carries the hypermorphic variant. The second child, who you'll remember had just a single cyst and post-axial polydactyly, was found to have a pathogenic variant in this gene called GANAB, which has been called the PKD3 gene, which is associated with features similar to ADPKD, but is a much more mild presentation. And it's not usually associated with cysts in children, and obviously doesn't explain his post-axial polydactyly. So in some ways, we could say this could in fact be thought of as an incidental finding. His father's also got this variant, and he in his 30s has got no renal cysts or liver cysts, and so it's quite hard to say what this could mean for him in the future, but this is felt to be a pathogenic variant. So this further case also caused a lot of problems, mainly because of the anxiety from childhood of the family being told that this child was likely to go into renal failure very early on, and she never did. So she was found to have a PKD1 variant, which was inherited from her mother, who we now know has got AD-PKD, and also a change in this gene, which is PRK-CSH, which is a polygenic liver disease gene, so associated with having liver cysts, which is classified as likely pathogenic and paternally inherited. Father has he's got one kidney cyst, but no liver cysts at the age of now 60. So again, it's hard to know the significance of this polycystic liver disease gene variant. And what I wanted to say is that this has been classified as likely pathogenic by the lab, which is quite interesting, in that obviously most people would say, well, but yeah, this is definitely disease causing, this is definitely important. I think it probably is, because this variant's in quite a few families in the literature as well. But likely pathogenic is the lab saying that maybe there's a 90% chance they've got it correct, rather than saying it's definitely going to cause disease. This final case is really to emphasise that there are some interesting phenotypes out there. So IFT140 has previously been associated with an autosomal recessive multisystem ciliopathy, but we now know that individuals who are heterozygous, so have just got one pathogenic variant, have a form of polycystic kidney disease, which is characterised by often having relatively normally sized kidneys but large extraphytic cysts. And this family, with this very asymmetrical disease, and the father having presented in a situation where there was a concern he might have a liver cancer, has got a variant in this gene. Okay, so I thought I'd include those just as vaguely interesting cases and me interpreting what I should do for the presentation. But why bother with genetic testing for a lot of people who are seen in renal clinics? So because I think the why bother often comes up because, well, does it change management? And actually very often it perhaps won't change management now for a lot of people. But a lot of people, patients that we see, actually they want to know why. And I think if that's the only reason for doing a genetic test, I think that's a very reasonable reason for doing a genetic test, because knowing why is important, and it might be even more important in the future if specific treatments become available. But also knowing what it means. For me, we often get a bit of prognostic information. Sometimes we come up with conditions which imply an individual should be having additional health screening. What it means for the family. Now, this is really important and can sometimes be missed when I know of a few cases where sadly it has been missed. Not intentionally, it's just not really been thought about when testing has been done in nephrology clinics. And that next step of thinking what it could mean for the family hasn't happened. But it can mean we can sometimes do predictive testing. We can talk about recurrence risk if people are planning pregnancies. And this is a thing that will often end up in not being dealt by the nephrologists per se, but should really be coming into our genetic counselling clinics, ideally. And there are quite a few reproductive options open to individuals. I've mentioned pre-implantation genetic diagnosis because it's often something that isn't thought about or known about that widely. And I've just put in a slide because people with quite a number of renal conditions are eligible for it. It's a type of IVF where there's testing during the IVF process to avoid a condition being passed on. Okay, so sorry, because I think I've spoken for much longer than was planned, but hopefully, yeah, and I'll be happy to take any questions when the time comes.
Not at all, Helen. That was really, really interesting and great to have those sort of real world examples as well. Any questions, if you think of them, just pop them in the chat and we can take those into the discussion at the end. And we'll now move on to a pre-record by Dr. Alice Marsden, who is an ST6 Registrar in Clinical Genetics at Liverpool Women's Hospital. So just to advise, this is a pre-recorded presentation, and Dr. Marsden apologises that she can't be with us.
Hello, my name is Dr. Alice Marsden. I'm a Specialist Registrar in Clinical Genetics. I'm sorry that I can't be with you live today, but please feel free to email me with any questions or comments. I'm going to talk about our experience of developing a renal genomics service in Cheshire and Merseyside. Before I start, I'd like to acknowledge all of the hard work that Dr. Emma McCann, Consultant Clinical Geneticist, has put into this project. I know she was really sad to leave it when she recently moved to Dublin. So what were the drivers for making a change to the current services? Well, the NHS is committed to becoming the most advanced genomic healthcare system in the world and delivering equitable genomic testing to improve patient outcomes. There have been several recent policies reflecting this. There has also been a new clinical genomics service specification on the horizon for around 4 or 5 years. So as a service, we have chosen to embrace the changes and try to anticipate what is coming. One of the key priorities of the new service specification is to embed genomic medicine into mainstream clinical pathways. And the North West Renal Network have also identified that awareness of and equitable access to genomic testing is an area of significant need. Our 4 main aims for the renal genomics service were to embed genomic medicine into routine renal care, to increase uptake of genomic testing for eligible patients with kidney disease, to improve the equity of access to genomic testing across the region, and to provide a joined-up, patient-centred service across the North West region. As the Cheshire and Merseyside Genetics Service evolved into Liverpool Centre for Genomic Medicine, we began to look at ways to integrate genomic care into different mainstream services. As a small service ourselves, it's not possible, or in line with plans for service development, to see every patient who's eligible for genomic testing. So a mainstreaming model really makes sense. Some services in the region have been early adopters of genomic medicine. For example, Liverpool Heart and Chest Hospital, where there is a well-established multidisciplinary clinic with consultant cardiologists and a consultant geneticist, seeing patients side by side to deliver care for patients with inherited cardiac conditions. So we thought about other services who had shown an interest in genomics in the past and might fit a similar mainstreaming model, and we felt that renal medicine was a great fit. I think it would be fair to say that our renal colleagues had been dipping their toe in the water when it comes to genomic testing for chronic kidney disease, but there remains a significant unmet need. Several recent studies have demonstrated a significant burden of monogenetic causes of CKD and shown that exome sequencing has a diagnostic yield of approaching 10% in adults with CKD. So we began by forming a renal genomics team starting in Cheshire and Merseyside, which consisted of myself, Dr. Emma McCann, and Jess Cadwallader, one of the genetic counsellors at Liverpool Centre for Genomic Medicine. We each took on an area of interest to develop. We mapped out the services across the region, which include adult services at Aintree, the Royal Liverpool, University Hospital, and Arrow Park Hospital, and paediatric services at Alderhay Children's Hospital. We then approached the different services, and it became clear that some teams were further along the process and had a greater genomic literacy than others. So we began the process of engagement, really aiming to understand and begin to remove the barriers to mainstreaming genomic testing in renal medicine. Once we understood how the renal services were being delivered, we were able to plan for regional development. Following on from the initial engagement meetings, we hosted a renal genomics morning for Northwest clinicians, which aimed to galvanise clinical knowledge on genomic medicine and help to integrate genomic testing into clinical practice. The event included workshops on genomic test selection, results interpretation and clinical application. We also aimed to facilitate a debate about opportunities and challenges. This word cloud highlights the main outcomes of this debate, including the ongoing need for clinician training to upskill renal physicians, along with a desire for multidisciplinary team collaboration. Despite some delays and interruptions due to COVID, we have made really good progress in establishing a renal genomics service. So our current footprint looks a bit like this. We have set up a monthly MDT on alternate Wednesdays and Mondays, which is attended by clinical genetics and nephrology across the Northwest region. In the MDT, we've just discussed over 100 cases to date and have recommended genomic testing in around a quarter of these cases, which avoids unnecessary referral to genetics in all but 11 of those cases where onward referral was recommended. And we also have links with national Renal Genomic UK meetings. Jess has established herself in the quarterly tuberous sclerosis MDT clinic. This is the perfect setting for a genetic counsellor to work independently, as all the patients have a known clinical diagnosis but may need input in terms of genetic testing or cascade testing for the wider family, or to discuss reproductive options. Also, the TS MDT clinic has recently become part of the Tuberous Sclerosis Rare Disease Collaborative Network. We have also established a care pathway for genomic testing for polycystic kidney disease and plan to provide genetic input in the cystic renal clinic to support genomic testing going forward. And I'd also like to acknowledge the hard work of our renal colleagues at the Royal, particularly Dr. Simon Williams, who's a renal registrar with a special interest in genomics, who has been running a monthly clinic specifically for patients who need genetic testing. As we all know, things never stand still, and this project is very much a work in progress. We are still shaping and developing the renal genomics service. Going forward, we're focused on making sure developments involve the whole Northwest region to ensure equity of access to genomic testing. As I've mentioned before, education is key to empower nephrologists to identify patients eligible for genomic tests and request the appropriate tests. The MDT meeting is also evolving with the introduction of an online referral management system. We hope this will streamline and standardise documentation of the patients discussed. The MDT is an excellent forum, but it does rely on clinical leads for each case to be present at discussion, which can be challenging from a scheduling point of view. Like most things, there is no definite right or wrong way of working, and we're still in the process of comparing and contrasting different options, such as MDT meeting versus MDT clinic, to develop the optimum patient-centred service. Thank you very much for listening. Once again, I'm sorry that I'm not here in person to take any questions, but please feel free to contact me via email if you have any questions or comments.
Okay, thank you so much, Alice, for that. And we're now going to move on to, we've got about 10-15 minutes left. If any of you have any questions, if you prefer to keep your cameras off and your mics off, I'm happy to, if you want to pop your question in the chat, I'm happy to read those out for you. So I'd like to invite our panel, Helen and Bill, to return, if that's okay, and any questions. I'll also just put up the feedback form there if any of you do have to leave, but we'd love to hear your feedback if you'd like more information and on what particular area you'd like that on. I'll hand over to the panel. Thank you.
Thank you, Lisa. I haven't seen any questions that I have to answer. We do appreciate, Helen, myself, Alice and the team over in Liverpool, that this is quite a transition in you adopting more genetic testing and having to think about providing this service within your already busy clinical services. And we are keen to support wherever we can. Our sense is that patients do prefer if they get that information from the people who are expert in the field and as part of their care package, rather than necessarily having to come and see us. Although, of course, for testing at-risk family members, it's entirely appropriate to seek our support. And when there are maybe complicated genetic test results that come back that might need some further interpretation, or as Helen flagged, the situation around pre-implantation genetic diagnosis, which increasingly families are wanting to, and couples are wanting to at least find out more about. They're not necessarily all deciding to go down that path, but we can have the conversations with them around eligibility and around what the process actually involves. Increasingly, our sense is that some of the genetic tests that are being used are not just informing reproductive decision making and risks to other family members, but increasingly the type of care that you can offer as clinicians in terms of the specific treatments that patients may be eligible for. And so, you know, I think there is that shift in dynamic around how families and clinicians want to use the information. So hopefully that is helpful for you.
So we've got a quick message in the chat saying thank you so much for the talks, and also to share a link for the free online course requesting genomic testing developed by NHS England National Genomics Education. So if you want to have a look at that, it's in the chat.
That's great. One of the other things that has been clear is that in the past, genetic testing was predominantly done by doctors, and in the future, more and more specialist nurses are going to be involved in delivering that testing and also to talking to families and affected individuals about their tests and what the results might mean. And, you know, nurses and nursing staff have a really important role in this space, because often they're the first port of call for patients to talk to about some of these more sensitive issues, or there are resources available that Lisa and others can share through the Genomics Education program, and a number of different ways of getting further information. But as Helen said, we're always keen to answer specific questions around particular families if you have those.
Can I check, are there any questions? Any hands up? Any more comments in the chat? Okay. If not, then I'd just like to thank Bill, Newman and Helen Stuart so much for giving these talk, and also Dr. Marsden over at the Women's. I hope she's enjoying her holiday. And also want to thank so much Selena Ahmed and Rainus Jones, who've been doing all our technical support today. And thanks so much to our attendees. Please feel free to pop any comments in the chat, and do complete the feedback form if you have time. And hopefully we'll see you all next week at the all-day renal event, if not before. So thank you so much.